I do have to do disclosures. I don't think I'm going to talk about anything today that's a conflict for me. I consult with companies that are trying to find treatments for CMT, so you want me to do that, but nothing that I'm going to talk about today sort of intersects that space. So this is kind of my overview. I think it's really comes down to a question like, why do my numb feet hurt and what can I do about it? So if that seems to be true for you, then it's a general truth. And it's not just people who have CMT, it's everybody that has neuropathy where the neuropathy causes pain. And so if you have numb feet, that sort of means that you have less appreciation of the natural stimuli that come into contact with the skin of your feet than you would have had if you didn't have neuropathy. And CMT is just a name for inherited neuropathies, but many people, most people with neuropathy don't have CMT. They have something else causing the neuropathy, and it's, in this country anyway, it's usually diabetes. So it's a common problem. I'm sorry, this computer's going to give me fits here. So not everybody that has neuropathy, however, will have nerve pain or neuropathic pain, same thing. Some people will, but other people won't, and it's not always clear why that is. So that's a question that I don't find an easy answer for. I can tell you that it's the damage to the sensory nerve fibers in our nerves that's thought to be the cause of the neuropathy pain. And so neuropathy damages nerve fibers, and it's the certain kind of sensory nerve fibers that we'll talk about later that are the source of the nerve pain that people feel. And based on that knowledge in part, but mostly based on just the luck of, giving people medications for other reasons and finding that they had an effect on nerve pain, that we actually have about 3 major classes of medications for nerve pain at this point in time. So I wish I could tell you that was all by rational thinking, but mostly it's by just luck of listening to patients. They're put on a medication for another reason, and they, lo and behold, found that it helped their nerve pain. So we'll get to that at the end of the talk. So here's the background from the scientific point of view. So this is a drawing, a cartoon really, of what's called the spinal cord. That's what's in the middle of your back, surrounded by bones. And the spinal cord contains neurons within it that actually leave the spinal cord, and their axons go down a nerve and make it to one of the many muscles in your body. And those motor neurons and their motor axons are the basis for how you make your muscles move. And we're not going to talk about them at all today because these motor neurons and their axons have nothing to do with the phenomenon of nerve pain. Rather, the sensory neurons, which live in a blob outside of the spinal cord, they have a connection to the spinal cord itself and a connection out here, in this case, to the skin. I'm going to apologize. This slide wants to do its own thing, and I don't know why. They have a connection to the skin, and it's mostly the skin, but not only the skin, that's the source of the nerve fibers that cause nerve pain. So anyway, so the important point of the slide is sensory neurons are the reason that we have sensation, and it makes sense that they're also the reason when things go wrong that you have nerve pain. And the motor neurons don't have anything to do with that. So a lot is known about this phenomenon. You have at least 3 major kinds of sensory neurons here in what are called the ganglia, this blob of neurons that are outside the spinal cord. And there are ones that subserve pain function. There are others that subserve how you sense your body's position, like why you don't fall down when you close your eyes. Those are called proprioceptors. And there are other ones that have the ability to tell you about mechanical disturbances of your skin. So when you touch your skin and you feel it, that's mechanoreceptors. But we're going to focus today on what are called nociceptors. These are what feel pain and temperature and subserve the phenomenon of itch. And in the clinic, I can use these 3 tools to sort of tell me something about the integrity of the mechanoreceptors with this tuning fork, the proprioceptors with a reflex hammer, and with a pin here, I can sort of, by touching it to the skin, I can have a sense of whether someone's pain sensation, pain perception is intact. And so Using these tools, I can actually make an informed deduction as to whether these different kinds of sensory nerve fibers are being affected by somebody's neuropathy. And I know a few people on this call I've seen as patients, so they're very familiar with me and my tools right here as the basis for judging that somebody has neuropathy and even how much neuropathy that they have. So I'm going to focus in on these pain-sensing neurons, the nociceptors. There are these little neurons that live in the dorsal ganglia, this blob. They're connected to the skin on one end. That's where they sense the pinprick sensation. And then they're also connected to the spinal cord, and that's where they tell the spinal cord, and that's relayed to the brain as to what's going on in the skin that's unpleasant. So if I poke the skin here with my needle, that information is conveyed here to the spinal cord and sent on to the brain. And that's how the brain knows there's a painful disturbance on my foot where somebody pushed the pin. So this pathway is well worked out, and it's worked out for the other kinds of neurons too, but I don't think that really matters to today's talk. If somebody has questions about it, we'll bring it up later. So these neurons and their axons are kind of special. So the pain sensing neurons and their axons are actually different than these larger axons that you see here. So this is a human nerve, and these Oreo cookie shaped profiles, those are big myelinated axons. Those are the non-pain sensing axons in the nerves. The pain sensing ones you can't even see here. You have to use a special microscope which lets you see these tiny, tiny nerve fibers here, these little blobs here that we see. There's probably 20 of them in this cross section. These small axons, which have no myelin sheaths, are in fact the pain sensing axons of our body. And their small size is probably part of the reason why they're vulnerable to many kinds of neuropathy, diabetes in particular, but many other kinds of neuropathy actually selectively pick on these little nerve fibers and damage them. And so having numb feet where you do the neuro exam and finding that the pinprick sensation is reduced in the feet, but we'll say everything else is normal, is a very common finding when I examine a patient with mild neuropathy. So their tiny size has a lot to do with that vulnerability. And so this is the slide that's worth thinking about for a minute. So this is a cartoon of a person whose neuropathy, we're going to pretend 20 years ago, started in their feet. And ever since it started, has just gotten worse and worse and worse in their feet. And then over time, the numb sensation that they first experienced in their feet has crept up their legs to the level of the knee and even subtly started to affect their thighs. And at the same time, started in the fingertips and then in the hands and has subtly crept up their arms. So if you have a bad neuropathy, you know this cartoon. This is the story of how your neuropathy has affected your appreciation of touch or pain sensation or temperature throughout your lifetime. So it didn't get this way overnight. It took years and typically many years for this to happen to somebody who has a form of CMT because that's a slowly progressive issue. But you, at the end of the day, are left with this sort of length dependent, as we call it, loss of sensory function in your lower extremities and even in your hands. So that's the key. And married to this phenomenon is the fact that when pain starts in somebody with neuropathy, it usually starts in the feet. So this is a picture that I loved from a patient who had neuropathy with nerve pain, whose feet were numb when I examined him, and he stood on a Xerox machine and did this image of his feet and then colored in with magic markers the fact that he feels this constant burning pain here in his forefoot, under his toes and under his foot. And then he has electric zaps of pain, which he cleverly made as lightning strokes over here. And those are the kinds of pains that he appreciated. And those are perfectly common. In fact, maybe the most common descriptions of pain that you'll hear. But I also, on the right side here, have people will also describe stabbing or crushing or pressure or stinging or itching and many, many more words that will describe pain that they experienced, usually first in their feet, but if time goes on, it might creep up their legs and even involve their hands. So when we talk about nerve pain or neuropathic pain, it's that pattern with those descriptors that make a good case that the nerve damage has indirectly caused pain. And what we have to think is that the nerve damage is to those little pain-sensing nerve fibers that were in that nerve biopsy I showed you. So that's the paradox that I started off with. You have numb feet and you have pain in the numb feet. And how does that make sense? I mean, how in the world does that make sense? You should think that you don't feel any pain because your feet are numb, but it's actually the opposite. The nerve pain typically happens in people that have numbness. So people have thought about this for a long time, and there's fairly convincing evidence that it's the damage to those little fibers, those little nerve fibers I showed you in that picture, that causes them to have spontaneous electrical activity, which is perceived by the brain to be pain. So how does that make sense? So if normally a nerve fiber is sitting there and its whole molecular design is to convey pain sensation to the body, and now it's not active unless it's encountering a painful stimuli, but now it's been damaged, so that nerve fiber is giving off the electrical signaling to the brain that somebody's stabbing it with an electrical discharge or doing something else to make it active, and it's therefore tricking the brain into thinking that there's something bad going on in the area of skin that it serves. So that's reasonably well established to be true. And calming that abnormally active nerve fiber down, you would think, is the logical treatment for this condition. And in fact, maybe we're on the verge of having treatments that work exactly that way. There's something called a sodium channel, that if we could slow down the activity of the sodium channel, the nerve fiber would be calmed down and we'd have a treatment for this abnormal activity. So that would be a goal, calm down the nerve fiber, but we're not quite there yet. The other points to make is that we have medications for nerve pain, but I want to say ahead of time, they're not effective for everybody. And also that there are it's important to distinguish nerve pain from other causes of pain that could happen to you, especially if you have CMT. You might have more arthritis in your joints, more tendonitis, sore muscles, sore joints, muscle cramps. Those aren't nerve pain in the sense that I want to talk about it. Those are other kinds of things. And the medications that work for sore muscles and sore joints, like ibuprofen, which is a non-steroidal anti-inflammatory, don't work on nerve pain. So if you're taking ibuprofen and it helps some kind of pain that you're having in your feet, I'm without a doubt going to think it's not nerve pain, because ibuprofen just doesn't help nerve pain. It helps other kinds of pain, inflammation-related pain, but not nerve pain. And it can be difficult. It can be challenging to figure out why your feet hurt and whether it's nerve pain or something else. And the simple answer is that if it responds to ibuprofen, ain't nerve pain. If it doesn't respond to ibuprofen, it could be nerve pain. That's more likely. So you don't have to know any of the things that I'm going to show you here, but I'm just trying to give you a sense that we know a fair bit about, of the 100 or more causes of CMT and the 200 or more causes of inherited syndromes that also have neuropathy that aren't called CMT. A number of them have a phenomenon of having changes in the pain level. There are some forms of CMT where the pain levels are reduced or absent, that people actually don't feel pain in their distal extremities. And some of these forms are to the extreme where there are even forms of neuropathy where people never feel pain in their whole life, that there's some key molecule that's affected that is necessary for the sensation of pain, and they no longer feel pain. So what we're talking about today, though, are causes of CMT that have enhanced pain. So there's a condition called TTR-related amyloidosis, Fabry disease, a form of CMT called 2J, 2B, and hereditary sensory neuropathy, where pain is actually enhanced typically. And even other rare disorders where pain is unbelievably bad all the time. However, in most kinds of CMT, and it's hard to give you a general truth, pain is a feature, but it's not in every single patient. It's in some patients, but not in everybody. And there are some forms of CMT called hereditary motor neuropathies, which only affect those motor axons, that they seldom, if ever, cause pain. So in the forms of CMT that we're familiar with, like CMT1A, the phenomenon of nerve pain in CMT and CMT1A in particular has been reasonably well studied. And I would say these papers and others give me the belief that about half the patients with CMT1A have some nerve pain in their feet and perhaps their lower legs and perhaps even their hands. It only gets bad in maybe 10% of those patients, so it might be present in half, but I would say from these papers, it seems that about 10% of the patients have enough pain where you might choose to try to treat it with a medication, but in the other 40%, they live with it. They don't take any medications for it. So it's been reasonably well studied, but I wouldn't say understood that this is a common phenomenon in the common forms of CMT. So the real question, I think, of greatest practical importance is what can we do about it? So I'll get to the medications in a moment, but first I want to tell you what my philosophy's been for now many years is that there are medications, but the goal of the medication is to make your quality of life better. So if I can make your pain better with a modest amount of medication that doesn't cause any unacceptable side effects, then that's a win. That's the goal. We want to find a medication that works, increase the dose until it's doing something good, but not causing unacceptable side effects. That would be the ideal. In the worst case, and it definitely happens, a medication, we don't have a medication that works for that patient. You know, the side effects are intolerable. Whenever we try to give a new medication, it just causes more misery, and that patient remains untreated. I would say more typically is you work with a patient to find a dose of a medication that results in some pain relief, and acceptable side effects, and then you got to find that, and you have to do that by starting at a lowish dose, increase the dose over time until you figure out that it's either helping or you're just getting side effects and it's not worth the effort. And if one medication doesn't work, then you try another medication. If that doesn't work, even another medication. And it's this stepwise, very deliberate, very empiric approach that you can find medications that I would say you can help most patients with CMT deal with their nerve pain. And so these are the big three. There's three families of medications that I think are well accepted to work for nerve pain. The reviews say it's true, and my practical experience says it's true. And I wouldn't say that, these are not rank ordered. I'd say all three are sort of equally well regarded in terms of their effects. So there's something called the mixed serotonin norepinephrine uptake inhibitors. That includes the brand name Cymbalta and the brand name Effexor. These are their generic names. So these work for nerve pain in, I would say, about a third to a half of patients with acceptable side effects. Gabapentin and the sister medication pregabalin are a second group of medicines. They work again in about a third of patients, up to a half of patients with acceptable side effects. And finally, the oldest medications on this list are the tricyclics. That includes Elavil, nortriptyline, diazepamine, and even doxepin. These have been around since, I would say, the 1960s. You use a lower dose of these medications for treating nerve pain than you would if you were trying to treat depression with these same medications. I don't favor Elavil most of the time because it's too sedating for most people, and rather nortriptyline or diazepamine are my two favorites of this group. And again, start at a low dose, increase it gradually, and hope that you get an effect on pain before you have an effect on side effects. The future looks more promising because of one medication in particular, and I hope it represents more to follow, which selectively blocks those sodium channels that I told you were involved with these hyperactive nerve fibers that produce pain. And so the very first one was approved in January of this year, and only for acute pain that after surgery in particular was this approved. But it gives me hope to think that selective blockers for the sodium channel called NaV1.8, and also there's a different sodium channel, NaV1.7, which are known to be key to pain. If we had selective blockers of those channels, I really would be optimistic that they would work on neuropathy pain. But as I talk about it today, I don't think, I'm sorry, I just lost the slide deck. I don't think we know whether this medication that was approved will work for nerve pain. Other sodium channel blockers, and I've listed them here, I haven't found to be particularly effective for nerve pain, so it remains to be seen what can be said about them. I don't think they are that good. There are some local anesthetic patches and creams with lidocaine, which some patients get some relief from, but it's not uniformly good. There's something called capsaicin, which is the ingredient in red hot peppers that has been formulated into a cream or patches. I haven't had good patient reports about this working. And of course, the big topic, medical marijuana, how well does that work for nerve pain? Well, we might hear from patients on this call some testimonials. It hasn't been studied in an officially good way to know how well this works on 100 patients. Any one patient might think that it works for them, but how it works across the board in comparison to the gabapentin and the other medications that I did mention, I think remains to be seen. In any event, this is regulated by both the federal and the state level, and what people's experiences with this and nerve pain happen to be, I'll say I've heard many anecdotes, and there's probably many people on the call who have tried them. It's sort of not formally studied in a way that answers the question scientifically. So that is my very short talk. And if I get out of it, I think you can see me back again. Yes?
Yes, we can see you.
So, I mean, the goal here is that there's a lot known about pain. CMT definitely impacts the topic of pain, and we have a limited repertoire of somewhat effective drugs at this point, and the hope is we'll have better drugs in the future, but the future is not here yet, perhaps with the exception of this new NAV 1.8 blocker, which I haven't personally had a patient on, so I can't tell you anything about it. Then I don't even know how restrictive insurance coverage will be if people wanted to try that as a medication, because a medication like that, at least initially, might have very restricted prescription limitations.
Gotcha. Excellent. That was a fantastic presentation, Dr. Scherer. I think more than anything, feeling there are probably some community members with us today who finally feel validated and heard, because a lot of their healthcare professionals tell them there's no pain with CMT, which I always say, find a new doctor if your doctor's telling you that. But this has been incredibly helpful. I'm going to jump over to the chat, and Riley and I can take turns with the questions. Some of the questions were addressed. The answers were found within the talk. So Jane, I'm going to skip your question because it says suggestions for activities to do in physical therapy. This is an excellent question. It's not the topic of the day though, so I want to make sure we get to pain management and CMT. Riley and I are planning for second quarter lunch and learn physical therapy and occupational therapy webinar. So stay tuned for that. We also have a lot of information on our website. Maybe someone can share that in the chat from our team. The next question came from John, and he was interested in foot and back pain solutions. He posted that early on, and so I think that those were addressed. As it relates to foot pain, would you say, Dr. Scherer, that some of these same strategies are used for back pain?
Yeah, I'm looking at, I figured out how to get to the chat, so I can perhaps don't go away, but so as I said, so people with CMT are more prone to having foot and ankle pain, arthritis in the feet and ankle, arthritis at their knee, arthritis at their hip, and probably even arthritis in their spine, which ultimately are issues that many people without CMT face as well. I can tell you that arthritic changes, you know, there's a small literature saying that gabapentin can help people with low back pain and perhaps other kinds of arthritis pain. That may be true. I don't think they're probably as good as nonsteroidals, but I'm not an authority on this. But by and large, those other medications that I talked about specifically for CMT or for neuropathy pain don't work for arthritic pain. And I'm absolutely sure that I've not seen nonsteroidals work for nerve pain of the kinds that I'm talking about today. So if you have arthritis, tendonitis, low back pain issues, gabapentin might help those a little bit, and that wouldn't be nerve pain per se, but I'm not able to tell you optimal medical or even surgical management of those conditions. In general, your primary would be the person to start with. A physical therapy person would also have a lot of knowledge about what non-medical, what non-medicine related therapies there might be for those conditions, but those aren't nerve pain. And particularly with the spine and low back pain, you know, working with your primary and your PT, and if it need be a surgical consult, that's the way to approach those issues.
Excellent. So do you want me to keep reading them to you? Do you want to glance at them?
I'll keep going.
Okay.
All right, so from another reader, what's the difference between diabetic neuropathy and CMT neuropathy? So people that have diabetes chronically, that is for years, have a risk of developing neuropathy. And if that's the case, we will call it diabetic neuropathy. If there's no other obvious cause of their neuropathy besides their diabetes, and they've had the diabetes furthermore long enough, that is years, then that's the likely cause. At the end of the day, the nerve fibers that diabetes typically affects are different than the nerve fibers a bit than are typically affected by CMT, but they are nerve fibers, and diabetic neuropathy will often cause pain. CMT will often cause pain, and I couldn't tell you in a person with both conditions with any certainty as to what the contribution was to diabetes and what's the contribution for the CMT. So that's a good question. Not so easy to answer in practical real life situations, but it wouldn't change if I was trying to treat the pain with medications. It wouldn't change the medications that I tried. They'd be the same.
Sounds good.
And here's a different question. So what are the common symptoms such as vibration in the feet, restless legs, numbness? I'm not sure I can make that into a question. So I talked about how you lose the sensation of vibration in your feet, like you lose the sensation of pinprick. So that's neuropathy. That's the mechanoreceptors for vibration. And the combination of those things results in the phenomenon that people would experience as numbness. And the restless leg issue is something different. So restless legs is a condition that happens more often with people with neuropathy than in the general population, but it happens in people without neuropathy as well. So I'm not sure if that answers the question. If not, you can raise it again, okay?
Thank you.
What's my experience been with
Tim, this-
acupuncture? Sorry?
You want to hold? I'm going to put you on speaker.
Hmm. That was probably someone that didn't realize they were
Okay.
on.
All
Yep.
right. Next question has to do with acupuncture. So acupuncture for neuropathy pain is probably minimally effective in most people. There's an occasional person who swears by it, I will tell you, but if you took 100 people and you gave them acupuncture, you would not be impressed by the results. So it's sort of like my feeling about medical marijuana. There are some people who swear by it, and more power to that person. But if you look at large numbers of patients, I don't think acupuncture has much going for it for treating neuropathy pain. In fact, people with neuropathy pain will often have like hypersensitive feet, like you can't bear to walk around in bare feet because your feet are just too tender. So that person is probably not going to do well with acupuncture as an added painful stimulation, if I had to guess. So
That makes sense.
you can come back to a question. Now, a much more complicated question. Let me read this. So somebody developed pain after a surgery on their feet, somebody with CMT. They tried gabapentin, which didn't help and had side effects. Lyrica didn't help. The possibility of trying naltrexone, which is sort of an anti-opioid, marijuana, opioids help. Anyway, that's too complicated of a question for this general call. So somebody who's having real pain issues after surgery could be nerve pain in the feet. It could be the orthopedic consequences causing pain in the feet. when you get to the point where you're using opioids for treating pain, you better be with somebody who's comfortable using them. This is not for the weak of heart, because opioids do work for all kinds of pain. The tricky thing is you don't want to make the problem compounded by becoming tolerant or even addicted to opioids, which is a rare but real possibility. So by the time you're doing that, it's become more of my practice to sort of recommend that people see a pain management specialist. The medications that I described in my charts, those are the ones that I think neurologists know how to use, perhaps even better than anybody else. But when you're into issues that are complicated, where you're using opioids, I think a really good pain management person is probably the one that needs to drive that car.
Excellent. And we answered a couple, but you could probably shoot down to Azul's, if I'm saying that correctly. This is an interesting question.
So when the nerve fiber is not actually damaged when it hurts. So what I'm contending is that the way you get neuropathy pain, at least in most patients, is that the little pain nerve fibers, the nerve fibers whose job it is to sense pain in your environment, they get damaged, and they create the situation where their hyperactivity is conveying to the brain the false idea that there is pain going on, but it's really they're fooling the brain because they're hyperactive. Those nerve fibers are affected in most neuropathies, and so pain is a pretty common phenomenon of most neuropathies. The main exception being those neuropathies that only affect motor nerve fibers don't cause pain. So it's clearly neuropathies that damage sensory nerve fibers and the pain sensing nerve fibers. That's how you get nerve pain. You think that answers it?
Yes. Oh,
Yeah. Sorry, am I allowed to talk?
sure, go right ahead.
I was the one that asked the question. So, cause like I get pretty severe nerve pain all the time from like whenever I use technology like computers and phones, or if I'm like reading a book too long. So I thought that when I got the pain that my nerves were being damaged more from whatever I was doing.
No. When you're feeling the pain, that does not reflect that you've somehow instigated more nerve damage. It could be like when it's positional, sometimes when you have less blood flow to your hands, like when you're using technology, like you get carpal tunnel sort of tingling in your fingers, that's actually blood flow to the nerve in your wrist that's being compromised by the way you're using your hands. And it's telling you, I'm not happy here, that is your hands, but you're not inflicting more damage by feeling more pain. You might want to make some adaptive changes to how you're doing things to minimize those bothersome symptoms, but I don't think there'd be any reason to think you're actually damaging your nerves when you feel more pain.
Thank you. Let's keep moving with the questions.
All right, Laura, you help me now. Go ahead.
Okay, so Barry had, and this may have been addressed, Dr. Scherer talks about why do his feet feel ice cold sometimes, and other times they're burning while sitting in the same room at the same temperature.
It's your damn nerves. So nerves, I don't know which phrases I've used over time, but the weird and mysterious things that your nerves make you feel when they're acting this way is it's a sort of a long list of adjectives that people used. Icy cold pain, burning hot pain, alternating icy cold, burning hot. Your nerves are creating mischievous feelings that your brain is interpreting in those waves, but it's the nerves' hyperactivity at the end of the day that's causing your brain to tell you that that's how it's feeling. But I do believe in all of those cases, no matter what you feel as the associated word, it's the hyperactivity of those pain nerve fibers collectively that's causing those sensations. And I won't say it's always, but it's almost the most logical thing. Those sensations start in the feet and move up the legs over time, and then maybe into the hands. So it's the longest nerve fibers that are known to be the ones that most affected by neuropathy, including CMT. And the center of those bad feelings is the distal feet in the beginning, and then later spreads upwards.
Gotcha. And then scrolling down, someone asked, what are the recommendations in treatment of genetically caused CMT? And I mean, there are, of course, no treatments at this time. I don't think they're talking about pain management because we've covered that. So they're probably thinking
That's a different topic that we probably have a good seminar or 3 on, don't you, Laurel?
Yes, yeah. And hopefully we'll have great news in
Right.
the very near future with
So-
we are and 3 human clinical trials currently, but there's no approved drug to treat CMT itself. So we're addressing
Right.
the symptoms as we are today in pain management.
Right.
Acupuncture came up again. Next question, is dizziness/vertigo a common problem with CMT?
No. No, if you have dizziness, vertigo, that would be uncommonly associated with CMT. There are maybe a few rare types, but the common types of CMT wouldn't be predicted to cause those kinds of issues because that's really dizziness in the sense of vertigo.
Mhm.
That's an inner ear problem and its connections to the brain.
Gotcha.
So not those nerves may be subclinically affected in many people with CMT, but not to the point that you get vertigo out of them.
Okay, that makes sense. And then someone asked about sympathetic nerve block
For pain.
or pain.
So anesthesiologists, pain management people do sympathetic nerve blocks. I'm not sure how commonly they're done because they're usually done for indications other than generalized neuropathy of the kind that CMT is. They're usually done for a limb, an arm, or a leg that has a pain issue that was caused by some kind of an accident or something. And it's one limb that you can treat with the sympathetic nerve block. They can work. I mean, I've definitely seen people who've gotten them and it's worked, but I've never, at least as I'm thinking about it from my memory, I've never seen them reported as being an approach for treating the generalized pain that neuropathy typically causes. So I don't think that's a real solution for people with CMT-related nerve pain.
Gotcha. Okay, that makes sense. Next question. This person says, I have had luck using double the recommended dosage of alpha lipoic acid. It felt similar to gabapentin without making me loopy. Have there been studies on increased dosages?
So thank you for that question. So there is a story about alpha lipoic acid and its use for treating diabetic neuropathy. And the data aren't all that great, and it's never been approved in America for the treatment of neuropathy of any kind. In Europe, it's used a bit more. And there are patients who take it as kind of a supplement. It's it's a natural product of certain plants. And so I can't speak to any harm that I've ever heard it cause. It just, for people that, if you put 100 people on it, you might have a few responders, but it wouldn't be the majority by any means. So I can tell you that everything I've known about it, it's safe. It's sort of a natural product. I don't know that taking more than the recommended dose has ever been reported to cause harm. You might want to check that out to see if there is such a possibility, but it's not used much. And I certainly don't prescribe it because it's not even prescription, right? It's something you can get at the health food store or even at your local Acme pharmacy.
Interesting question. Okay, next question. This is, well, you decide if it's in your wheelhouse. Dr. Scherer, can you please address the pain associated with CMT affecting respiratory muscles that cause respiratory impairment?
So I don't think I can answer this question, not because I don't want to, but I don't think so. The questioner, so the respiratory muscle, the way you make your muscles move are those motor nerve fibers. Motor nerve neuropathies that only affect motor nerves, and there are many, don't cause pain almost ever. And therefore, pain with respiration wouldn't be anything, I think, directly to do with the ability of your nerves to make your diaphragm muscle move up and down to help you breathe. There might be some interwoven complication, like, we've all experienced pain when you take a deep breath of some kind or another. That's called pleuritic pain. But I I don't think I can make the connection for us there because it's not a typical place or a typical kind of pain you would get with neuropathy of any kind, and I think that includes CMT.
Gotcha. And then Jane, who had asked about physical therapy, she came back to clarify that what she was referring to was managing pain in physical therapy.
So physical therapy as a means of addressing pain issues is pretty effective for the orthopedic issues of mankind. I would say that that's almost always a good place to start. So for hip, low back, neck, you name it, those kinds of pains, physical therapy has a proven benefit to helping us get through those episodes and preventing future episodes. For the kind of burning pain that attacks your feet at night, I can't picture how physical therapy could help that, and I don't know that I would have confidence that it would.
Yeah. And then Lisa Marie was just sharing that she had a remarkable neurologist who she was talking to about CMT pain. That she picked up through the question that she also had fibromyalgia, and it changed her life. That it was no longer an assumption that her pain was coming from CMT. They also discovered fibromyalgia. So I guess we as patients should make sure that the doctors and that we ourselves are not assuming every pain in our body is coming as a result of CMT.
Well, I love the last statement of that question. So yes, I mean, the fact that you have CMT, I mean, it's to my dismay when people with CMT will come and tell me that their doctor told them that such and such a thing that they were having was coming from their CMT when it's not. So fibromyalgia, I can't tell you that I have any great knowledge on this, but fibromyalgia, the pain that I've been talking about again and again, it's like starts in your feet, spreads up your legs, maybe in your hands. Fibromyalgia pain is usually not that kind of a pattern. It's pain that can have sort of any kind, it can affect your body in any place that it wants to, and it wouldn't typically behave, in fact, wouldn't be expected to behave like neuropathy pain, which it starts distally in your feet. So if you're having other kinds of pain issues, I wouldn't jump on the train that that's got to be your CMT. I would in fact resist it. That, you know, what else could it be? Because it doesn't really fit CMT type of pain. And I think that's what the doctor picked up on and came away with the diagnosis that maybe the other pain issue was fibromyalgia, which interestingly responds to some of the medications that I listed for nerve pain, but it's a different mechanism probably driving the pain of fibromyalgia. Doesn't have to be damaged nerve fibers. It could be something else.
Okay. Next question. Any research regarding CMT and CMT pain regarding the Rife machine?
Well, I think Rife is an aggressive form of physical therapy, if I remember this correctly. And I don't think that that would directly have any impact on the CMT nerve pain that I've been talking about. I've heard of people using the Rife techniques for like chronic low back pain and that kind of a thing, but not for nerve pain.
Okay. Do you feel, and I'm going to mess this up,
Topiramate.
topiramate is an acceptable medication for CMT nerve pain?
So topiramate is a sodium channel blocker, as are a couple of the other ones that I had on my last slide. You know, they're certainly less reliably effective than other medications that I talked about more in detail. Individual patients may have a benefit from it. So topiramate, for instance, is used a lot for treating migraines prophylactically. And we know that it's a sodium channel blocker. So it just doesn't work in my experience or in the experience of the literature as reliably as the medications that I have come to prefer. So there's nothing that I can say that it couldn't work in individual patients, but you're really, as kind of a third line agent in the list of what's first, second, and third. It's not something that works reliably enough that it would be used commonly unless everything else failed and you were looking for something else.
Okay, gotcha. The electrical feelings that we experience, is that from the myelin sheath wasting?
So the electrical feelings that you have, we'll say the ones that are like the pain ones, those come from those nerve fibers that I showed you this electron micrograph of that have no myelin. Those are the littlest nerve fibers in our body. They don't have myelin. And so it doesn't have anything to do with myelin, but Rather, the lack of myelin might leave these fibers, these nerve fibers, more vulnerable to the insults of the environment than the ones that are myelinated. So it hasn't anything to do with myelin pain. It's the ones that don't have myelin that are driving the pain show.
Gotcha. Does gabapentin increase your risk of developing dementia?
Well, I don't know what medical school and neurology residency your aunt went to, but it must have been a good one because I don't know anything about this association.
Okay, so we will not take that as factual at
wouldn't-
this time.
I don't, please don't take medical advice from people who you wouldn't go see as a patient.
Yep, got
So,
it. Stick with
know.
the experts. This comes up a lot in the community. What about electrical nerve stimulation, particularly methods like the TENS unit? Can that help with pain relief in CMT?
So I've had a bunch of patients use 10 units. Some of them had CMT, but mostly it was for other reasons. So I think TENS units have a role to play in conditions like chronic low back pain and that kind of thing. I don't know how best to represent them to you, but I think they kind of distract you from your sources of pain. They sort of, you feel this electrical pulse in your skin from the TENS unit. And I think that sort of is an effective distractor from this, we'll say, nagging low back pain that you otherwise have. I don't think there's an experience that I can promote their use for ordinary nerve pain of the kind I've been talking about. So again, it could be that an individual patient out there finds them to be wonderful. But if you subject large numbers of patients with nerve pain to them, you won't be impressed by the results.
Okay. Stewart says, what has research shown about ganglion blocks, central nerve stimulators?
Well, those are big questions, Stuart. Ganglion blocks would be like those sympathetic blocks that I talked about a moment ago, where for pain that's limited to a limb, there's the possibility that sympathetic blocks will be beneficial for that pain thing, but that's not the kind of pain that typical neuropathy produces. So I wouldn't promote the idea of sympathetic blocks of both the arms and the legs as a treatment for somebody's nerve pain. Spinal cord stimulators, I don't have a well-formulated opinion about them. The way medical devices are subjected to clinical trials is much less rigorous than are medications that are proposed to be used in people. So the bar for using a device in a patient is, does the device work as intended? And that might be enough to get it approved. How well it works isn't necessarily well shown for the stimulators. And then so selecting the right patients who might benefit from the device and all of that kind of really hard stuff to do, I think that's yet to be done. So certainly there are people who have had stimulators put in, and I've had patients like that. I wouldn't say it's a uniformly good experience. There are complications of these implants that can happen. And I've been sitting on the sidelines, I'll say, waiting to be convinced that would be a good thing to try in somebody who hasn't responded to traditional medical approaches. So I'm not saying that couldn't work. I'm just saying that's an invasive thing. I haven't seen it work reliably enough for me to want to recommend it to my patients, though if they wanted to do it on their own, I don't oppose them either.
Great information. Any thoughts on infrared therapy to help with neuropathic pain?
Well, I think this is one of those treatments there that you can go on this assumption that if the medical insurance that you have won't pay for it because it's not been FDA approved, then it probably hasn't passed the bar of proof that you would want to see in order to embrace it as a therapy. So there are many treatments like that, including sort of TINS-like units where maybe they work in some patients, but they don't work reliably or well enough that insurance companies will typically pay for them. And so I sort of take that as a sign that they're not effective enough in enough people for me to sort of get on board.
Gotcha. And then our very own Dr. Catherine Forsey is asking, any tips for dealing with neuropathic itch? It's so annoying. It feels like hundreds of mosquito bites on the shins in that area of reduced sensation.
So that's that's one of the many descriptors that I would call that nerve pain first. And secondly, I would try the medications that work for other kinds of nerve pain as an approach. You could even try if it's a well-circumscribed area, you could even try the lidoderm patches to that or the lidocaine creams to that. I mean, if you have an area that's discrete and not your whole body, it does promote the idea of trying a local therapy for that particular person's issues. But I don't think the mechanism driving that abnormal bad sensation is different than that's driving any of the other kinds of nerve pain issues that I've been talking about.
Okay. Stuart's asking about supplements such as magnesium, B complex. I know that could be a whole nother meeting probably, but
well, unless you're truly deficient in a key vitamin for whatever reason that you are, then the idea that supplements are a panacea for treating neuropathy or nerve pain, I don't think is correct. I think that you if you're deficient, then take a supplement. Whether that supplement helps your issue, you alone have to be the judge. But if you're not deficient, just taking supplements at large hasn't been shown to improve people's health.
Yes, that makes sense. Next question. I have what feels like muscle fatigue pain on arms and hands with minimal exertion. How is this different from neuropathic pain?
So I can't tell you the basis for muscle cramps and muscle aches kind of pain. I don't understand what drives that, so I don't want to say I can answer that, but I do think it is different. I do think it is different because it's a use-related phenomenon that people will typically experience. In the case of cramps, it's like something that wakes you up at night if you've experienced them and really hurts. But they're not nerve pain issues in the way that I've been describing neuropathy pain.
Got it. Irma's asking about if there's a correlation of Epsom salt foot soaks being helpful in managing pain.
Have not heard of that.
And again, it's probably one of those, if you soak your feet in Epsom salt and feel better, perhaps there's your answer. Is there any medication that can be used for both nerve pain and orthopedic pain, or should they be addressed separately?
So with the exception of gabapentin, which might work a little bit for some kinds of orthopedic pain, I think I've said that a couple of times. I think that the non-steroidals don't work on nerve pain, and the medications for nerve pain don't really work on musculoskeletal / orthopedic pain. I think that they have different mechanisms and they don't work on each other's issues.
Okay. Anything non-medicinal that helps with burning pain in the feet and with restless legs?
Well, if you find the answer, please tell the rest of us because I
Yes.
don't know it.
Reach back out to us, please. Okay, let's see. Some thank yous. Bruce
So
is asking about,
I want to answer the tonic water one.
that's what I was
Just 'cause-
go right ahead. Yep.
So muscle cramps, they're a terrible and common problem with people with neuropathy, and CMT is certainly high on the list of what bothers people. So there is a sodium channel blocker out there, and it's on my list called mixilotine, which might work for some people with muscle cramps. So some of my neurology colleagues have used it more than I have. And it's possible that the mechanism driving muscle cramps is a hyperactive motor nerve fiber, which makes your muscle cramp, and mixilotine can calm that hyperactive down. So I would, if it's a bad enough problem, I would encourage you to work with your neurologist or primary to see about a dose escalation of mixilotine to see if you can get some relief, because some people do get relief with it, and there's no disputing it. It's a little tricky to use the medicine. You have to sort of start low and build up and make sure that you're not having any cardiac issues from it, because it's also used for cardiac arrhythmias. But maybe some some hope there.
Excellent. Thank you, Dr. Scherer. I am going to wrap us now. We're at the hour out of respect for your time and everyone else's time. That will be the end of our webinar. I am happy to stay on for a few minutes. I'm sure Riley can stay on. And if any other CMTA staff members want to stay on and chat or answer other types of questions, we're happy to do that. But I just want to thank you, Dr. Scherer, for being with us today. It was an incredibly informative meeting and truly answered so many questions. I really, really appreciate your time.